In this talk, I'm going to focus on the fetal CNS infections, clues, diagnosis, and management. I'm going to start what are actually ultrasound, because the truth is that we don't routinely screen for all congenital infections, and it can vary from one country to another. And the more likely scenario that you see something on the ultrasound scan that makes you suspect that the fetus might have congenital infection and therefore trigger testing. And I'm going to demonstrate that through a few cases. So this case, for example, it was referred because they saw that it was early onset fetal growth restriction. The biometry was less than 10 centile. There was oligohydramnios. There was actually abnormal triarch Doppler, and there was echogenic bowel. So you think actually, well, yeah, it fits into early onset fetal growth restriction. But when you do the ultrasound scan, at the end of the scan, I thought actually that's unlikely to be genetic or placenta insufficiency, but actually more likely to be congenital CMV infection. And why did I say that? Well, there is something here on ultrasound, the periventricular halo, which actually made me suspicious of the fact that it's congenital CMV infection. And there's another case that was a twin pregnancy that she's 31 weeks, spontaneous dark twins, and was referred because one of the twins had bilateral severe ventriculomegaly. And you can see here that each twin has we scan in different color. And one twin had the ventriculomegaly, also the thick echogenic ventricular walls, and also there were sort of some suspicious of intracranial hemorrhage, and the other twin was completely normal. So in this case, we obviously do the investigations of ventriculomegaly, including testing for TORCH, testing for the antibodies for the platelets. You do amniocentesis, and you do an MRI, and MRI confirmed what we saw on the ultrasound scan, so the severe ventriculomegaly affecting one twin with no other associated brain abnormalities. And then the TORCH screen come back as positive for toxoplasma. And guess what? Actually, both babies were positive for toxoplasma. So you can have one twin infected and the other twin not infected. They could also have both of them infected, but they have different ultrasound findings or abnormalities. The third thing I want to highlight is the fact that we had this recent outbreak of Parvovirus B19 with the first article that really pointed out was this Lancet letter in the Lancet on the right-hand side, 4 fetal medicine centers in Europe, across Europe, reporting a massive increase in the number of transfusions, and they were mainly because of parvovirus. Why I'm saying this in this talk? And you see here, this is data from Germany, and you see the massive increase in number of cases of acute parvovirus B19 infection in pregnant women. Because if you look at the ultrasound features of parvovirus B19, often present with severe fetal anemia, resulting in fetal hydrops. You will see sometimes you see the hepatomegaly, the placentomegaly. Sometimes you will have the echogenic bowels. So some of these features do overlap between one infection and another infection. So they might not be necessarily very specific. Also, sometimes you have the polyhydramnios if the baby is severely anemic. In case of parvovirus, you can have also cardiac changes because they can sometimes have heart failure. So they can have the cardiomegaly, the pericardial effusion, the tricuspid regurgitation. But something that's very relevant to this talk, and the reason I mentioned or included parvovirus, is this reports of brain abnormalities associated with fetal or congenital parvovirus B19. And I appreciate it is controversial, but the reason I included them in my talk, because in this recent outbreak of the wave, we've seen cases of parvovirus that did the transfusion, and when we followed up this baby, we started seeing some brain abnormalities like small cerebellum, for example, or cerebellar hemorrhage. So if you look at the literature, you see that actually, yes, there are reports of brain abnormalities, often maybe cerebral hemorrhage or cerebellar hypoplasia, which could be symmetrical or asymmetrical, some cases of intraventricular hemorrhage, maybe some cases of ventriculomegaly, or maybe subtle imaging changes that could result from the bleeding in the brain. So is actually parvovirus causes brain abnormalities? Is it teratogenic? And the consensus that it's not the virus itself that actually causes the brain abnormalities. Is not necessarily teratogenic, but in the fact that is the fact if the fetus have severe anemia and fetal hydrops, that there are independent risk factors of long-term neurological sequelae, and the fact because this baby have anemia and have thrombocytopenia that can result in bleeding in the brain. Okay, so what are the ultrasound features that if we see that actually make us suspicious of the fact that there may be congenital infection? Well, if you group them into cranial abnormalities, so things like ventriculomegaly, intracranial calcification, intraventricular synechiae, or cerebellar abnormalities, and they can really vary whether they are cerebellar hypoplasia or Vermeer hypoplasia or calcification in the cerebellum, or even cerebellar cyst. Or periventricular pseudocyst, or maybe the more severe end of the spectrum, things like cortical malformation or lissencephaly or schizencephaly or polymicrogyria. And in the very extreme form where you have actually microcephaly. So that's the cranial or the cerebral abnormalities. What about the extracranial abnormalities? Things like small baby, which is the case that I showed you earlier, the referral with just early onset fetal growth restriction, the echogenic bowel. You see the hepatosplenomegaly, which is not specific to an infection. So you see the number of infections, sometimes liver calcifications, or sometimes ascites or precardial effusion or skin edema or hydrops without anemia. But also sometimes you can have a mild degree of anemia, for example, in case of congenital CMV infection, or sometimes severe form of fetal anemia, like in cases of parvovirus. The placental or amniotic fluid abnormalities, you can have placentomegaly, you can have calcification in the placenta, they have oligohydramnias, sometimes even anhydramnias, like what I showed you before. So if you have any of these features, don't forget to test for infections. So how do we actually diagnose when we find these abnormalities? Well, in order to diagnose congenital or fetal infection, often we will do an amniocentesis. Again, that can vary according to the specific infection, but let's say, for example, CMV or toxoplasma. In this case, we will do an amniocentesis. We test for either CMV DNA or the toxoplasma PCR and amniotic fluid. I think the key thing is really to make sure that you time the amniocentesis correctly in order to avoid the false negative results. So often we will ideally have 8 weeks interval between the maternal infection and the amniocentesis, ideally beyond 20 weeks, but certainly we can sometimes do it earlier. And there's some reports of even testing the CVS or the trophoblast in the first trimester for CMV to allow us to have first trimester early diagnosis. I think one very important role of the fetal medicine specialist, once the diagnosis is made, is to assess the severity of the fetal infection. The prognosis. Is this fetus or this baby is likely to be symptomatic? Is it likely to have disability secondary to this infection or not? And in order to do that, there are 3 things that we can actually use. First is the timing of the maternal infection. Second, which is very relevant to this talk, is the presence and the type of fetal abnormalities, because they can vary in terms of the prognosis. And the third is a laboratory test. So I'm going to try to cover each one of them. So the timing of maternal infection, the general rule, for example, in CMV, is that the later the infection in pregnancy, the more likely that actually the virus will cross the placenta from the mother to the baby. So you see here the chance of vertical transmission is higher in the 3rd trimester compared to if it happens in the 1st trimester. First trimester is about 30% in cases of congenital or CMV infection. But you see exactly the opposite pattern when you're seeing about the chance of severe symptoms at birth. In fact, the chance is, or the risk is much higher when the infection occurs in the 1st trimester or in the periconceptional period compared to when it occurs late in pregnancy. In fact, in late in pregnancy, the risk is negligible. So where is the data to support that? Well, if you see this meta-analysis that was looked at the timing of primary maternal CMV infection and the chance of vertical transmission. So here, the gestational age of the infection. See here, this is a transmission rate. The blue is the fetal insult if the fetus is infected, and the green column if if we don't know whether the fetus is infected or not, because, for example, the mother declined amniocentesis. And what you see here, that the chance of transmission is higher, of course, later in pregnancy, but the chances of fetal insult is higher early in pregnancy, in the first trimester, compared to later in pregnancy. What about the chance of being symptomatic at birth if the fetus is infected, or even if the fetus is not infected? You see the risk is much higher if it occurs in the first trimester compared to the third trimester. And again, if you look at the chance of sensory neural hearing loss or neurodevelopmental impairment, again, the risk is mainly really in the first trimester. So there is more and more evidence that the infection that really matters is the one that occurs in the first trimester or in the periconceptional period. So why is that? Well, if you look at the critical periods of human development, and you see here the central nervous system, and you see the light shaded area is the time of greatest vulnerability, and the dark shaded area is the time of lesser vulnerability. And you see here for the central nervous system, it is early in pregnancy, it's the first trimester, the time of greatest vulnerability. So if the infection and the fetus get infected at that time, is the one that's likely to result in insult and brain damage. So that's about the CMV. What about the toxoplasma? Do you see similar pattern? Very similar pattern, in fact. So you see the mother-to-child transmission is about 30%, as I mentioned earlier, and you can see this data or these figures from toxoplasma. The transmission increases at the gestation, but the severity tend to be less later in pregnancy compared to early in pregnancy. When you have toxoplasma, when we published the ISWAC guideline, we did say we recommend that we should arrange an ultrasound scan every 4 weeks. And when you do the ultrasound scans, you look in particularly for brain abnormalities, for the eye, and also assessing the growth, because they have higher chance of fetal restriction. So when you look at the brain, what brain abnormalities should I look for? You can sometimes have the ventriculomegaly, like the case that I showed you earlier, but sometimes you have the thick ventricular walls, or maybe sometimes you have cystic lesions or brain cyst, or the calcifications. And the calcification can be in different locations in the brain. And characteristically, this calcification tend to be quite thick, almost like areas or plots of calcification, compared to the CMV, which tend to be mere finer calcifications. But be careful. In toxoplasma, even if the imaging throughout the pregnancy is normal, there is still about 30% risk of long-term sequelae, especially the risk of chorioretinitis, which might not be diagnosed during the pregnancy, and sometimes that can lead to increased risk of visual loss later in life. Okay, so if you remember, I did say at the fetal medicine doctor, our role is to assess the severity once the diagnosis is confirmed. And one thing is the gestation at the infection, maternal infection. The second is the abnormalities. And for CMV, the good news that if you have a normal brain, using ultrasound, detailed ultrasound, and MRI throughout the pregnancy, the chance of infant disability is extremely low. But that does not include the chance of hearing impairment. So we have to be careful when we counsel the parents. If the normal MRI, normal detailed neurosonography, reassuring, but we cannot rule out the chance of hearing impairment. The other thing which is very important to realize that sometimes actually the initial assessment, let's say at 20 weeks or in the second trimester, is normal, there's no abnormalities, and these abnormalities might actually become apparent only later in pregnancy. And therefore, it's so important that we need to continue monitoring and doing detailed assessment on a regular basis up to 12 weeks from the presumed maternal infection. And sometimes it's difficult to know for certain when actually the mother had infection because there's no symptoms. And to even repeat the ultrasound scan, repeat the MRI throughout the pregnancy. The other thing also, you need to be aware that the appearance of the brain or even other organs might vary with gestation. So the case that I showed you earlier, the one that was referred for early onset fetal restriction, the initial assessment, for example, you didn't really have all the cortical abnormalities that became apparent later in pregnancy. Also, there was no hepatomegaly, for example, in the initial assessment, there's ascites, and therefore you need to be systematic when you do the assessment throughout the pregnancy. I mentioned earlier that not all abnormalities have the same severity or have the same prognostic value. And this is for congenital CMV infection. This is potential classification. It's not necessarily being validated, but it's been proposed in one of the studies of sort of differentiating between what would be severe brain abnormalities compared to mild, and what about the extracerebral abnormalities. And it's important to highlight that, for example, even if you have ventriculomegaly, the prognosis is different from mild to severe. Of course, if you have severe ventriculomegaly in the context of congenital CMV infection, it's likely to have more severe outcome compared to if you just only have mild ventriculomegaly or just a calcification or just adhesions, compared to if you have cortical abnormalities, for example, or lysencephaly or microcephaly. So what we should do, well, we should do targeted neurosonography in any case of suspected or confirmed fetal infection. And of course, just to remind you of the ISWA guideline, it was covered earlier during the day. So in this case, you need to have not just the axial views, which is sort of would be the low risk, transventricular, transalveolar, transthalamic. Actually, no, you expected to do the extended or detailed neurosonography. We're looking at the coronal view, the four planes, transfrontal, transcaudate, transthalamic, transalveolar, and also the sagittal views, so the mid-sagittal and the parasagittal views. What about the MRI? Should we be doing MRI if we actually do detailed neurosonography? Does the MRI have value in cases of congenital CMV infection? And the answer is yes. So it is true, if you look at the data in this paper, we published it a few years ago, that the combination of you have ultrasound and MRI in the late second trimester, 25 to 28 weeks, the negative predictive value is quite high. So more than 80% for symptomatic infection. So you can reassure the parents, of course, as I mentioned, without it's excluding the chance of hearing impairment. But if I have a normal MRI and normal ultrasound scan, there's still residual risk of sensory neural hearing loss, and there's about 15%. And certainly there are some structural anomalies that will only be diagnosed by MRI, fetal brain MRI, not really diagnosed by ultrasound. That's about 10% of the cases. And still there are some anomalies, brain anomalies that only exclusively diagnosed at birth or postnatally, even with normal prenatal imaging. And we have to obviously be careful and warn the parents about this risk. What I would propose is to actually have this checklist approach. And if you do your neurosonography and not just being looking, is actually looking with targeted, means I am looking, I know what I'm looking for, and I have a checklist for each of these planes. So for example, the transventricular plane, what I want to tick the box in presence or absence is microcephaly, ventriculomegaly, the intraventricular adhesions, intraventricular hemorrhage, the periventricular echogenicity, the cyst, and if I have a cyst, I comment on the location, the number, the type, intraventricular calcification, underdeveloped Sylvian fissure, wide subarachnoid space, that there are so many features or ultrasound signs that they can actually either confirm that they are present or confirm that they're not absent, even when I'm looking at just a transventricular plane. I think what I'm going to do over the next few minutes is to go through each of this ultrasound abnormality or finding and discuss with you what their prognostic value. So for example, if you have microcephaly, a microcephaly is diagnosed when you have a head circumference less than 3 standard deviation below the mean. Okay, how common is ventriculomegaly in cases of microcephaly in cases of congenital CMV infection? Well, its huge variation is about from 19 to 28%, because in fact, if you look at the literature, the diagnosis of microcephaly varies, and the cutoffs, sometimes they use 2 standard deviation. But if you have a congenital CMV infection, increase the chance of microcephaly by about 7-fold. And when you have a microcephaly, it's rarely encountered in isolation. In fact, I had a case with congenital CMV infection, and the brain was completely normal, and just the head was small. And is it actually microcephaly in relation or secondary to CMV, or is actually just a small head? And interestingly, when I met the father had a very small head, and I measured it and definitely had a small head. And therefore, the small head in this context, with a completely normal brain, did not have the same prognosis as microcephaly with associated brain abnormalities in case of congenital CMV infection. And in fact, this baby carried on throughout the pregnancy completely normal and had a normal outcome, at least was not symptomatic at birth. So be careful. Certainly, if you have a microcephaly, it is a strong predictor of adverse poor prognosis, particularly of motor disability. It's about 92% if the baby is symptomatic, and for mental retardation, it's about 100%. So it's quite a specific predictor. What about if you have ventriculomegaly? And as I mentioned, of course, if you have severe ventriculomegaly, it's worse than if you have mild ventriculomegaly. If you have ventriculomegaly, be careful. Go and interrogate this area of the periventricular zone, the echogenicity, looking for the cyst or interventricular adhesions. And certainly, if you just have a ventriculomegaly, so routine 20-week anomaly scan, and if you have bilateral ventriculomegaly, when you do the torch, the chance of CMV is only about 1%. It's a small chance. What about the periventricular echogenicity, or this periventricular halo, which is in one of the first case I showed you, is what made me think that actually this is a case of congenital CMV infection. You often see it in the early stage of the disease. It's secondary because it presents inflammatory ventriculitis. And it can, certainly it's one of the leading markers of fetal CMV infection, and they don't necessarily have the same appearance later in pregnancy. They can progress into cavitation or abnormalities of the gyration. What about the intraventricular synechia or the periventricular pseudocyst? And they, again, the pathologies are because they are result from necrosis or hemorrhage in the germinal matrix. They're often located in the germinal matrix. Look at the caudothalamic groove or the lateral aspect of the frontal horns of the ventricles, and best demonstrated in the frontal view or of the coronal views. And of course, when you have extensive destruction, you will have the intraventricular synechia. And be careful, because you need to differentiate the periventricular pseudocyst from the periventricular leukomalacia. And how would you do that? Well, this diagram beautifully illustrates the difference. They have different location. The periventricular leukomalacia is usually above the external ankle of the lateral ventricle. That's the frontal horn of the lateral ventricle, while actually and that is associated with spastic cerebral palsy or visual impairment, while the pseudoventricular or the periventricular pseudocyst is actually often located inferior to the external angle of the frontal horn of the lateral ventricle. The intraventricular synechia is almost considered pathognomonic. If you see it, pathognomonic of CMV infection, you don't really see it in other pathology. And be careful, because you might miss it if you're just looking at the coronal planes. It's best demonstrated in the axial or the sagittal plane. What about the intracranial calcification? They can vary, and again, the prevalence varies in the literature, but the results, why do you get calcification? Because of white matter damage and calcium deposits in the damaged tissue. They can also, they're not specific to CMV. I showed you earlier in cases of toxoplasma. CMV, the commonest place is the periventricular region. What about posterior fossa abnormalities? They can really vary from hemorrhage in the cerebellum, cyst or vermi hypoplasia, or cerebellar hypoplasia. So why they have hemorrhage in the cerebellum? Because CMV can lead to anemia, often mild, but they also can lead to thrombocytopenia. The lesion can sometimes bilateral or can be unilateral. Cortical abnormalities, obviously the most severe, and CMV is the commonest infectious cause of polymicrogyria. They can vary from being focal, diffuse, unilateral, bilateral, symmetrical, or asymmetrical, but certainly they tend to commonly involve the Sylvian fissure, and you can assess the Sylvian fissure either on the axial planes or better in the coronal planes. Finally, the lenticular striates vasculopathy, and I'm really mentioning it because be careful, because when it's isolated, they usually have good prognosis. This is the only thing that you see in the brain. In absence of other brain abnormalities, they often have good prognosis. So what do you see? What do I mean by them? This tends to be hyperechogenicity. They see it in the brain, and they follow the lenticular striate branches of the middle cerebral artery, and that's supplying the basal ganglia. So back again to my approach or suggestion is that you have this checklist approach in the various planes in the detailed neurosonography as per the ISWA guidelines. So here, the transventricular plane, I've already gone through this list before. When you go through the transthalamic plane, this is the things that you might come across. The transcerebellar plane, I mentioned about the posterior fossa abnormalities. The coronal planes, again, you can see still, you can demonstrate the ventriculomegaly. You can see the adhesions and you can see the hemorrhage. You look at all of the, or the late sulcation, you can look at the Sylvian fissure, and again, the sagittal plane. This is the abnormalities that you might encounter when you're doing this mid-sagittal and the para-sagittal. Okay, so that's about the brain abnormalities and the targeted neurosonography in a case of fetal infection. Particularly, I focus very much on congenital CMV. But what about other infections? And certainly this is a list of the brain abnormalities that have been reported in the literature in association with Zika infection. And this was mainly really back in 2016 when we had this epidemic, meaning South America, of Zika. But what's really important, and the reason I would like the message I want to bring here, is the fact that a lot of these abnormalities or brain abnormalities, they do overlap actually with congenital CMV infection. So be careful when you find this, particularly with microcephaly, with associated brain abnormalities like calcification, like cortical abnormalities. Don't forget to ask about travel history, particularly if you've tested for CMV and it's negative. Don't ask about travel history, particularly to an area where you know that Zika is endemic. So back again to our ability to assess the severity, the prognosis. We said about the timing of maternal infection. We spoke about the fetal abnormalities and the type of abnormalities, and they have different prognostic value. And finally, the laboratory. And we know that viral load in the amniotic fluid or the fetal blood is associated with the higher the level, the higher the chance of being symptomatic at birth. But be careful because the virus is excreted in amniotic fluid, and therefore it might not be that specific. So, for example, if you have brain abnormalities, it's questionable really whether it's valuable or it's essential to do fetal blood sample if you already have brain abnormalities that are associated with poor prognosis. Other things is the platelet count. So we know that if you have low platelet count, you have higher risk of being symptomatic at birth. So back to the ISWA guideline on the role of ultrasound in congenital infection, do we have to do fetal blood sampling? And the answer is no, because in fact, if you already have other features that already help you to make the prognosis, maybe it's not essential to do fetal blood sampling. Prognostic algorithms, and there are already a few really that's been published, and the numbers are small, they need to be validated, but certainly having some combination of ultrasound findings with level of the CMV, DNA and amniotic fluid, or the fetal blood results like platelets, for example, platelet count, and the performance or the ability to help us to predict the chance of the baby being symptomatic at birth. I'm not going to go through that. But importantly, once you made your assessment, once you did your detailed neurosonography and you've done the MRI, you can group these cases of congenital CMV infection into one of these three categories. Green, they color-coded, like traffic light. Green, there's no ultrasound abnormalities, the brain MRI is normal, and therefore we can be really reassuring to the parents that the chance of disability is very low, except for the chance of residual risk of hearing loss or hearing impairment. The red, the already severe ultrasound abnormalities, particularly the brain abnormalities, the already cortical abnormalities, the severe ventriculomegaly, the prognosis is poor, and in this case, you could potentially offer termination of the pregnancy depending on where you work. And then the group in the middle, which is the orange or the yellow, which is the mild to moderate. So there is some ultrasound abnormalities, but they may be mild ventriculomegaly, maybe just some isolated intracranial calcification. And in this group, it's really difficult because it's not always associated with poor prognosis. And this is a group that you might want to consider doing maybe follow-up, looking for progression, but also perhaps maybe considering treatment. And I'm going to show you in a couple of slides about the potential benefit of the valacyclovir in this group. So can we actually treat these cases. So we have confirmed diagnosis of congenital CMV infection. You've done amniocentesis. The group is on the mild or the moderate. Can we actually do and make it the treatment? And this is the data on the use of valacyclovir in cases of congenital CMV infection. This was a multi-center open-label phase 2 study that was not randomized controlled trial, but this study from the French team demonstrated that giving the high-dose valacyclovir to these women, these pregnant women, reduced the chance of being symptomatic. So increased the chance of being asymptomatic from a historical group of control, so a group of pregnancies that did not have treatment, and the instance of being asymptomatic at birth was about 40%, and increased the chance of being asymptomatic at birth about 80%. But still, of course, it wasn't a randomized controlled trial. It was just almost observational data, and therefore it's not routinely recommended in all the guidelines. But what this study provided is reassuring safety data on the use of valacyclovir in pregnancy. There was excellent maternal tolerance, even in this high dose. That's a 2 gram every 6 hours. So it's 8 gram in total, so about 16 tablets a day. It's quite a high dose, and there was no harmful effect on the baby. So really, to summarize, if you have a case of, let's say, CMV infection, you made the diagnosis, you've done amniocentesis, and the fetus is infected. We do the detailed targeted ultrasound scan, and it's not enough to do it only once. You need to repeat that every 2 to 4 weeks. We do arrange an MRI 28 to 32 weeks, and sometimes even repeat it later if there are some subtle findings that we want to look for progression. And you might want to consider the fetal blood sample if the prognosis is questionable, or particularly in the group, the orange group. And you group them into either the green, asymptomatic, which is in this case, we monitor until birth and the baby get tested at birth, or the red, the severely symptomatic. In this case, we could offer termination of the pregnancy or expect a management, or the group in the middle, which is the mild to moderate. And this is a group that in my current practice, I would discuss the option of starting treatment with valacyclovir and monitor the pregnancy. And of course, don't forget to test at birth and send the placenta for examination. Can we prevent it? And this is what the evidence on the use of valacyclovir. This is from randomized controlled trial, single center from Israel, where actually if the mother gets primary infection in the first trimester or in the periconceptional period, when they randomized these women to either the valacyclovir with this high dose or placebo, and they looked at the instance of vertical transmission, giving the valacyclovir reduces the transplacental transmission by about 70%. And this is randomized controlled trials with level 1 evidence. And the current practice, if you diagnose first trimester or periconceptional maternal primary CMV infection, the recommendation is to give the valacyclovir. So really my take-home message that we need to have a systematic approach. You need to do targeted neurosonography. It's not enough just to do the axial views. You need to do MRI. You need to consider repeating the neurosonography and maybe repeating the MRI. I think our role as a fetal medicine specialist is really to assess the severity and assess the prognosis. And I did mention about the possibility of antenatal treatment. And these cases can be quite complex in their management and their counseling. And therefore, it's important to have a multidisciplinary approach. Thank you very much for your attention. And I'm gonna happy to take any questions.